So thank you very much, and thank you for having me here today. I'm going to speak specifically about the STIs in the context of the Ryan-White HIV/AIDS program, and just a 1-minute overview of those of you who don't know the program. The Ryan-White program is about a $2.3 billion annual investment in providing HIV care and treatment for people who don't have means to get that care and treatment on their own. We serve about 500,000 people a year, a little over 500,000 actually, and that represents over half of all the people with diagnosed HIV, so really deep into that program. Of those people, 2/3 of them live at or below the federal poverty line. 75% are people of color. So we definitely are meeting our target population, and it really shows how concentrated the HIV epidemic is in the United States. So in the Ryan-White program, we are able to in some ways address some of the social determinants of health. The program is set up to provide both core medical services as well as support services, things like transportation, emergency housing, emergency food, child care during appointments. So we have that flexibility that's not found in other medical programs, and we think that's why we've helped us be successful. Of all the people that come into our program, and as you see, it's a group of people that would generally have a lot of significant health disparities. About 86% of people that come into care at least once are virally suppressed. So we do a tremendously good job, and that really is about the people that are completely committed in the communities that are providing this treatment. The other piece is that all the programming is really done at the local level. By statute, people at the level of the city and state governments that we fund, as well as the community-based organizations, decide what their needs are and how our program can fill in the gap. So we don't do that priority setting at HRSA, they do it locally. That said, we view that we have an important role in moving the program forward. Can I have the next slide? So I'm going to talk specifically about the epidemiology of HIV and STIs, the impact in the population, STI testing in the Ryan-White program, the work we're currently doing, because we know we've got significant gaps in future considerations. Next. So I'm looking at who's in the room. I probably didn't need any of these slides, but when we look at the epidemiology of STIs in HIV and co-infection, and it's important to know that in the Ryan-White program, we are very, very data focused. That's how we've focused our efforts in the last few years. We know that men who have sex with men have increasing burdens of primary and secondary syphilis and antimicrobial resistant gonorrhea and obviously HIV. And among men who have sex with men in the United States with primary and secondary syphilis with known HIV status, almost half are HIV positive, which is remarkable given the overall epidemiology of syphilis. And similarly in Florida, among those people diagnosed with syphilis, 42% were HIV infected. Next slide. So I'm bringing this up because we have a real challenge around getting extra genital testing done, and that's been a real focus of our work in the last couple of years. You can see here, based on the epidemiology of extra genital gonorrhea, chlamydia among MSM, you can see that those with HIV infection are more likely to have rectal gonorrhea, rectal chlamydia, pharyngeal GC, and pharyngeal chlamydia. So it's really important that we, and obviously that pharyngeal chlamydia is based on testing, the way the tests come back. But you can see that we do have an increased prevalence among people, men who have sex with men. So we need to make sure we're getting to extragenital sites. And there are a couple of different studies that up to 1/3 of all infections are going to be missed in gay men if we're not testing extragenital locations. Next. So we also know that STIs increase risk of HIV transmission. There's a strong association between primary and secondary syphilis and newly acquired HIV infection. A study done by the CDC attributed about 10% of HIV infections to gonorrhea and chlamydia infections. Chlamydia infections have been associated with increased risk of anal dysplasia and anal cancers in men who have sex with men and HIV. And we know that, and there's some evidence that co-infection with STIs is associated with decreased CD4 count and increased viral load. And there is some evidence that people with HIV may be more susceptible to acquiring STIs. Next. So when Gail, this is a study from Gail Boland, who I guess is going to be here later today or was here recently. Oh, there you are. So you go. There you see it, Gail. So when we look at Ryan-White funded facilities versus facilities not funded by Ryan-White, we can see that in terms of STI testing in the last year among HIV positive men who have sex with men, those in Ryan-White funded sites are more likely to be tested for syphilis, gonorrhea at any site, anal or pharyngeal gonorrhea, chlamydia, any site, anal chlamydia, and hepatitis C. So we're doing a good job, but not a great job. The hepatitis C is a little bit, we only recommend hepatitis C testing at baseline when they first come into care, and then annually if they're at risk. So that numbers overall, or numbers of hepatitis C testing is about 90%. But for the others, you can see that we do okay, not perfect, and we certainly are not doing well at extragenital sites. Next. So in terms of what we can do in the Ryan White program, our legislation manages quality management for all of our programs that we fund. So we use that as a big carrot and a little bit of a stick. So we do have annual STI screening that we check at chart reviews during site visits, and if it's not done, that's a site visit finding. We also have performance measures that include chlamydia, gonorrhea, and syphilis, and so that is something that we measure in our we have our recipients measure as part of their quality program. The challenge we have with that, when we look at our data across the board, like how many people got syphilis testing, we know what the numerator is. It's unclear sometimes what the denominator should be. I, for example, still practice, and I have patients who decline their syphilis test. I said, I have not had sex in 15 years. Don't spend my money on a syphilis test. Next. So we've done a couple of things because we know that we need to be improving our rates of testing. Also, in our statute, our providers have to provide care consistent with federal guidelines. So that's very helpful to us when the federal guidelines are clear. So we know that people with HIV should get tested at least annually. For men who have sex with men who are continued at high risk, it's every 3 to 6 months according to the STI guidelines. And so we know that doesn't always happen. We know that's not happening. And we know that extragenital testing is not happening. Gail and I have been in conversation for years now, I can say, around improving extragenital testing. Some of the challenge has been that our recipients haven't been able to access places where they can send their tests. That's improved over time, but continues to be a challenge for some people. There continue to be challenges of labs not being ready to get those tests, so they get two gonorrhea tests the same day, and they throw one of them out, not knowing one is rectal and one is oral. They just don't. We're having those challenges too. And then some insurances don't want to pay for multiple tests from different sites on the same day because they can't really distinguish it in how the billing happens. So we know we've got different challenges there. With that, we have partnered with the Bureau of Primary Healthcare, and we worked really closely with Gail's group at the CDC Division of STD Prevention to develop a framework to test what are the best interventions to get our recipients to do these things that they're not currently doing. And I can say that our providers are really very, very committed to providing high quality care, and many of them have quite a bit of cultural humility around taking care of gay, transgender people. So we know that there's a lot of interest out there. We just have to help them get there. So we sought to develop a list of interventions that we could have be tested in a pilot setting in 3 different jurisdictions at both the clinical service level and at the systems level, because we at HRSA work in public health. So we fund primarily health departments and state and city health departments. So that gives us a lot of leverage because they know how to sort of do things at a systems level, like looking across the entire jurisdiction. Where are the pockets? How can they reach those people in the pockets? They can look at quality of providers and how do we get that provider to do better testing. So we really want to work at the systems level. And I'm saying that because when it came to actually setting things up, we had a very hard time finding systems level interventions to do. So we fund 3 jurisdictions that we funded one grantee, and they had to work with 3 jurisdictions. Each of the jurisdictions had to have a sort of jurisdictional convener, and then we had to have at least 3 clinical sites. So Rutgers, it was an open competition. Rutgers won that competition, and they are working with the state of Florida, Louisiana, and DC. The other thing that we are doing is, in some places, there's excellent linkage between the STI surveillance and the HIV surveillance. The systems are well linked and everything is working well. There are some jurisdictions that haven't been able to make that happen yet. So in this past year, we funded through a competitive grant program organization to help work with individual jurisdictions that wanted to better link their STI and HIV surveillance system. So we've also funded that as part of their HIV work. Next. So as part of the as part of the cooperative agreement where we're working with jurisdictions to do better interventions at the clinic and systems level, we convened a technical expert panel. We brought experts from around the United States together to help us think through what are those interventions that have proven evidence or looks like there might be evidence there that we could then implement through this new initiative. So what we found out through that technical expert panel, some of the issues are issues I'm sure you're hearing here routinely. One is that we don't really have a sexual health framework in the United States. People don't talk about sex very much. It's fascinating to me the number of people that work in HIV who haven't had that discussion with their kids yet. I mean, it's just bizarre. So that's a huge barrier that we have. We also, in working with community health centers, we know that there's a lot of stigma that goes on with providers around sexual health. The whole discussion of PrEP is really going to be fascinating as we try to really implement it at a public health level, because you have to have that sort of sexual health framework and a non-judgmental approach to people's sexual practices. So, that was a very important part of it. The other thing is that providers still don't know what they need to know about STIs. We know that providers are not getting good sexual histories. So for that reason, the interventions that were chosen based on that baseline needs assessment performed at clinical sites is we're going to have a training module, once again working with Gail's STD prevention training centers. We're going to be using some of their training modules to train clinicians at these sites in STIs and to be better informed about how to screen and how to treat. We're going to use an Academies system to sort of bypass the clinician to get a good sexual history. That'll then be printed and included so the clinician will be able to see it as part of that visit. Once again, to bypass the clinician, we're going to start doing self-testing more in sites. Self-testing is done really well in some sites and not at all in others, and it really does change a little bit of your workflow. You need to have a bathroom available as patients are checking in and other things. So we're going to start really increasing the ability to do self-testing. And then we're going to work to get more LGBTQ welcoming spaces. And we have a number of strategies around doing that. Once again, there isn't a lot of data about how you actually make that change, but we're looking at people. The Fenway's been funded by the Bureau of Primary Healthcare for years to help increase the LGBTQ cultural competence of community health centers. We're taking some of the work that they've been doing. At the systems level, we're doing provider detailing. We're going to have expert clinicians train providers at their clinical settings. Next. So main considerations as we move forward from the work that we've done is obviously we're very interested in reducing disparities around STI acquisition, testing, and treatment among people with HIV. We need to work to decrease stigma around STI acquisition, testing, and treatment. It's still a lot of stigma even among people who have HIV. I think everyone that's worked in the STD clinic has probably seen patients that have a regular HIV provider, but they're too embarrassed to go to their HIV provider because now they have an STI. At least that's been an experience I've had several times. People still have a lot of stigma and don't want to be outed among the regular provider around that. We need to be able to increase routine extragenital testing, and if that's self-testing or other mechanisms, we need to figure out how to do that. And then address providers' knowledge gaps, including taking a good sexual history, appropriate STI testing, and then issues around cultural humility. So we need to increase patients' comfort about reporting their STI risks and seeking STI treatment and ensuring an adequate supply of benzodiazepine penicillin, which I didn't mention here, but it's certainly been a major challenge we had a year or so ago, where people would go for weeks and weeks with secondary syphilis and not be able to get access to drug. So with that, I will close and sit over there to have a discussion with you. Thank you.
Thank you very much. Why don't I just kick it off with a question? A Hopkins WHO group publishing in BMJ Global Health, I don't know when it was, this year, highlighted that both they and a Cochrane review found that self-testing was associated with a lower proportion of positive results, even though it was a demonstrable way of improving breadth of results. What are your thoughts about that trade-off between increasing testing but perhaps getting a somewhat lower yield for positives, presumably based on the the quality of the self-testing sample.
Right, well, I think if you do the math of where we're starting from, if we had 100% of self-testing and it was 30% worse, we'd still be in the, we'd still be in an advantage.
I
So
thought you might say that.
I think that's where we are with that. That said, I do, so in my clinic, I do testing of everyone. We don't have self-testing set up because they don't have the flow in there yet. And I have to get a chaperone for all of the rectal tests. So just, it slows everything down. We do it, but it's challenging.
And that seems amenable to modeling, doesn't it? I mean,
Absolutely.
One could. Ned and then Jeff.
Laura, thanks for joining us today. Your interventions and efforts are focused largely at providers. And as you know better than I, our providers are just completely overwhelmed by the number of things that are prioritized for them to do. I was wondering whether there were any direct-to-consumer patient initiatives to sort of help drive STI testing.
Yeah, so I think so that's a great point. I think in places like Seattle, there's some places where people know they should get tested all the time and want to come in and get tested. As part of the self-testing, there's going to be a component of really training patients that they should be getting testing for those that are at risk every 3 months, and then developing a system where they don't necessarily need to have a clinician's appointment. They come in, and if they screen for negative symptoms, they just go on to get testing. So that is part of the initiative, but you're right, we should be doing more there to drive demand.
I guess my question's related, just really at the provider level. You mentioned a number of barriers, but I'm just wondering how much is this driven by resource constraints at clinics, or is it that, like, I have a perception that maybe doctors managing HIV care, if someone's not, adherent or suppressed, that's such a priority that STI is just at the bottom of the list. Is that a concern? And like, I know we have ideas, and Ned talked about them, about self-collection and things, but it still feels like, I don't want this to be like this boutique idea. How do we get to scale on some of these things? So it's just, we're routinely just screening a lot more. Like, do you have a prioritized list of what the provider barriers are? I guess that's my question.
Right, so I think one of the challenges we have now actually in HIV care is we only see patients once a year. So you see patients once a year, you do have that much longer laundry list, but I think STIs still remains a significant concern for clinicians seeing people living with HIV because they're aware of the STI risk.
Thanks, Laura. I have 3 questions, so but I'll ask them kind of order. First, in terms of the Ryan White programs, it's only fairly recently that HIV negative clients or HIV negative people were permitted. What percentage of the budget is for the providers that are supported by programs supported by Ryan White? Do you have any sense of how much is for negative PrEP kind of activities?
Yeah, so we don't. So in the Ryan White statute, we don't have any clinical services for people that are HIV negative. So we cannot support PrEP in any way. The people that are HIV negative in our program it's really in the family-based models of care usually. So we're not providing clinical services to those people. We might be. I'm thinking like a child of a mother whose mother's HIV infected and the child is not, that we might be able to provide some sort of wraparound services to that child, but it's a negligible.
Small percent, so it's a small activity. And then the second question is, I'm kind of surprised, so the providers who are now HIV providers, they actually, you feel substantially many or some number don't know how to manage STIs, even after all these years of Ryan White and all this focus on this measurement. That's something you said, but it really remains a siloed problem.
It remains a siloed problem, I think, because STIs are still relatively specialized in medical care. I would say, a lot of STIs have been sort of relegated to STI clinics and primary care providers. So a lot of Ryan White providers are seeing 150, 200 patients. So they have a large primary care practice, and HIV is a part of it. And they keep up in their HIV. They go to a meeting because they're the HIV expert in these smaller communities or towns. But STIs are just another thing on top of that. And, how do I treat gonorrhea? It keeps changing. May I just complain to Gail about that? It keeps changing how you treat these different diseases based on resistance and other things. So I think they know they don't know, and that makes them anxious.
My last question is the most difficult. This is the time where your organization, your leadership is critical to the epidemic activities. And I've heard in the last 2 weeks 10 end the epidemic lectures, most impressed by Admiral Giroux. My question is, I guess, I've been concerned that there's this disconnect between this particular committee and the ETE activities. Just an opinion of how you see, and this would be an opinion or a thought, how do we connect with ETE? To not recognize that ETE is a 900-pound gorilla right now would
Right.
not be right, but we don't really know how to connect these, so if you could comment.
Yes, I think you definitely need to be connecting them. We also have the first federal action plan around STDs that's going on now, and that's happening here. We've got the EHE, ending the HIV epidemic. We have the National HIV/AIDS strategy. We've got the hepatitis elimination. So we've got these 4 things that are happening. They're all happening under Admiral Giroir, as you just mentioned him. So I think there are opportunities to do that, but we need to, because they all feed onto each other. I'm really excited in the Ending the HIV Epidemic initiative. The community health centers are going to be sort of given the responsibility of doing PrEP for uninsured people. Well, the community health centers have not done a lot of sexual health work, and you really have to reframe around sexual health. So I think that is an example where now they're going to be talking to people about their sexual risk. And if we start talking about their sexual risk, you start talking about sex, you're going to change. Hopefully, they'll certainly be doing more screening related to that. So I think that they all come together, and you should definitely be better connected.
Thank you for your presentation. I really appreciated your point about addressing the social determinants of health that you mentioned in the beginning. And I was curious whether all of the programs and clinics were kind of doing that, the integration of the social care and the medical care. And if not, did you see differences in outcomes between those who did and those who didn't? And if so, and if they are there different kind of facilitators to different clinics and programs being able to do that? So I'd love to hear more.
That's a great question. So most of our funding goes to city health departments and state health departments, who then do needs assessments in their communities, figure out where the gaps are, and then on the city side, where most of the services are delivered, the states mainly supply medication. But on that side, there's a community board that actually, planning council we call it, that actually figures out what needs to happen in the community. So at those levels, we're much more likely to have better integration of things like housing services and transportation services. At the local clinical level, we are seeing a lot more of that now. We've really been encouraging clinics to look at, once again, data-driven, who is out of care, why are they out of care, and what can you do to better address care. So at the local clinical level, they're less likely to have a housing program, but that's starting. They're more likely to have transportation services. All of our programs are heavily reliant on case managers who are linking to community services. And when we actually look at what makes a successful Ryan White program, they're often multidisciplinary teams, but they have linkages into the community. So they know how to access those community services, and it's considered part of care. For a Ryan White provider, they have to keep people in care. That's one of the things that we look at and measure over time, so that when I always say, if I never came back to my medical doctor, she'd never notice. But if you don't come back to your Ryan White clinic, someone's going to notice, and eventually they're going to go out and try to find you or connect with you in some way.
Vincent, did you have? No.
Thank you so much for a great talk. So I have 2 questions. Some of the barriers seem mutable. So for example, the scaling up of laboratories, and I was wondering if there's a federal initiative to improve laboratory access for these extragenital testing. And then the second question is insurance companies, what would make them convinced that this is an important thing to do? Like, do we need modeling, or what do we need?
So so on the lab side, I defer to CDC. Gail can probably talk more about that and the work that's being done there. And I guess there's some questions too, like have studies been done where you could put the rectal and throat site all in one sample, for example, and that sort of thing. And obviously there occasionally where you'll want to know the difference in terms of what you might consider for treatment, but overall, that if it improves things and makes things happen more cheaply or easier, we might do that. With insurance companies, I think that if you call them and explain what it is, they're usually willing to do it. It's more when it comes through on the billing. So I think it's more in their billing algorithms than them being unwilling to do it, if that makes sense.
Great talk, Laura. I have a question, wondering, is it possible to do something like a structural intervention using electronic medical records to have standing orders in the Ryan White clinics that automatically, based on risk, order rectal and pharyngeal cultures Pooling does work, and there are places that have validated that. That does save money if you can just test one test that has a sample of urine and a rectal and a throat sample all in one test, because most of them will be negative. So it does save money. But using self-collection, could not this benefit the screening for HIV if there are such things as standing orders that are intervene for the clinician to say, oh, the standing order is I have to order extragenital testing, or I have to order some STI testing?
Yeah, I think that's a great idea. I know that there's an ongoing study done at the clinic where I work, I'm sure you had a part of it, Johns Hopkins, where they did that, where the extra, should you be testing for extragenital, sort of popped up at every visit for every patient. I don't know what the overall impact of that was, since people tend to just get rid of those as quickly as you can over time. But yes, so I think that would be a great idea. Part of the challenge is that then you have to have, and I think the Academies could help you with this, normally in an EMR that have so much information in them, you might have done some sexual history once in there, but usually that's not something that's entered into the EMR in a systematic way at every visit. Like I ask at every visit and it's in my dictated note, but not in that click button part of the EMR. So definitely something worth considering, and probably link to an Academies that goes into the medical record, which is something that could certainly be done.
Thank you, Laura. I have a follow-up question on your slide on your ongoing STI initiatives within the Ryan White program, and particularly these jurisdictional conveners and the 9 clinical sites. Could you say a little bit more about that? Are these aimed to be demonstration projects that ultimately will be scaled up? Will there be capacity to do that?
Yes, thanks for asking. So this was done at our Special Projects of National Significance, which is the demonstration arm of the Ryan White program. And it's a small, we have about $25 million a year, and this is a $4.3 million project over 4 years. So it's a pretty big investment for us of that program. And that is exactly it. It's to figure out what is actually going to work, what is doable, and then scale it up. And we purposely sort of chose the convener with 3 sites because we were trying to sort of mimic sort of that public health model, or looking at that model where it's not like an individual clinic doing this, but it's a jurisdiction trying to take this broader approach. So if it does work, it would be relatively easy to infuse into our other sites across the country.
John, last question.
Thanks. So there's always been this sort of firewall, like you mentioned, between the kind of positive care for positive folk and care for negative folk, and the concept of family, and I wonder, I mean, are there and I don't know if this is at the HRSA level, but changing statutes. So I can imagine as the concept of family evolves, and so it may be that preventing an STD in a partner is an intervention to prevent STIs in the index HIV, person living with HIV. So I'm wondering, what sort of, are there any pushes to change statutes or change the program?
Yeah, so the Ryan White program is overdue for reauthorization. We were last reauthorized in 2009. That expired in 2013. So we're overdue for reauthorization. There's been a lot of discussion in the community about that, sort of having a status neutral approach to things, which you do not have in Ryan White, where you get sort of quickly cut off if you're not living with HIV. So there has been discussion, particularly around PrEP and program income. So the program does have program income related to the 340B program, and shouldn't we be using that to do PrEP and other things so we can have a more status neutral approach to people as they come into care? Addressed in the community at this point, this administration has been very interested in reauthorizing. They've been talking about reauthorizing in terms of in the last 2 presidential budgets. But they're really waiting for Congress to take the lead on that, and I think Congress is really working with community about figuring out when that right time is, and so it hasn't been something that's, I think, on the brink of happening in those discussions as I've heard them.
Dr. Cheever, we could talk to you all day, but this was extremely helpful. Thank you very much for joining us.